So welcome to Orlando. Welcome to this MDA-sponsored session on spinal muscular atrophy. You've already heard from Blake, and you'll hear a lot more from how much the MDA offers for our patients with SMA. And we have a nice lineup of speakers to follow me to talk about more specific topics. I'm Richard Finkel. I'm a neurologist. I treat children principally with nerve and muscle disorders, and I have a particular focus of interest in spinal muscular atrophy. I work here in Orlando at the Nemours Children's Hospital, which is just down near the airport. And there are a lot of familiar faces in the room, but a few unfamiliar faces, so I welcome everyone. And you'll get to meet some other members of our team today. Later this afternoon, there will be some roundtable discussions and opportunities for more open questions. What Blake asked me to do this morning was to give more of an overview of what is SMA in the current context of these different emerging treatments, and what are these treatments, and how do we try to get our head around this? So with that, I first want to start with my disclosures. And because I do get grant support from a variety of resources listed here. I'm an advisor to virtually all the pharmaceutical companies that are in drug development for SMA, and I've served in a variety of different capacities, and this can introduce some bias, and I'm going to try my best to give you a balanced overview of everything, but I've been fairly involved in the SMA area for several years, and I'm going to share with you my passion, but hopefully not my biases, and give a balanced perspective. Okay. So this might be familiar to those who have SMA, who are living with it, or have a child with SMA. And we break the spectrum of spinal muscular atrophy into these groups, type 1, which are the little babies, and historically, and that's the point I want to make, historically, these babies did not live very long, half of them not reaching their second birthday. And then the type 2 children who sat but never walked, who would typically live into the later years, teenage years, perhaps beyond. The type 3 who presented later in childhood and had a normal life expectancy but might lose walking over time. And then the type 4, which is an uncommon form of that presents in adulthood. And the point I want to make here is that this is historical. This does not exist today. So if you really look at the current situation, you almost have to ignore this, because this is not really what we're living with today when we talk about children with spinal muscular atrophy, adults with spinal muscular atrophy who are under treatment, because this is changing. I think it's important that we keep this in mind, but we don't get fixed on this, because this is a moving target. And every day when I see somebody in my clinic, I'm surprised at seeing how different it is from what we'll call the old days. So we are in need of a new classification system for SMA, and that's being developed. Some of us in our group are working with others internationally to try to develop a new classification scheme that better reflects the current world of SMA that we live in. So if you were to look at some of the medical reports and journal articles, you'd see charts like this, and you would see where a child would be born and then have a life expectancy that would decline over time, and this is for type 1, and there was a predicted time when nutritional and ventilation support was needed. This has all changed, or it's changing, and again, I think we need to look at these more as a historical reference than as a reality. With these new emerging treatments, I want to emphasize that it's still critically important to have good standard of care. These treatments are not a cure, and hopefully we'll get there someday, but these treatments provide meaningful benefit. They truly are miraculous drugs, and they do not work, however, without good supportive care. So I want to emphasize that I believe it's quite important to follow what are called the standard of care guidelines, and that's illustrated on this slide. And so, of course, we want to make the patient at the center of all the focus here with the family, and you need someone to coordinate it. And that coordinator might be a parent, it might be the pediatrician, it might be a neurologist or some other care coordinator in a program. But as you're all familiar, there are multiple different aspects of living with SMA to include digestive issues and pulmonary concerns and orthopedic management, medications and the such. So with this idea in mind, there have been a couple different efforts internationally to develop what are called standard of care guidelines. And there's a couple points I want to make here. One is that these are guidelines. They're not written in stone, so they need to be adapted to each individual. And the second point is that there were some standard of care guidelines that we put together in 2007, and then they were updated in 2017, and they've been published, and that's listed on the right here. And those are available for reference. They talk about 9 different topics, and those are listed on the left, from how do you try to properly focus on the diagnosis of a child or adult suspected to have SMA, and what should the genetic counseling be, things of that nature. And then, as listed here, nutrition, growth and bone health, and I'm going to touch on these in a moment. The pulmonary support is very important, and Dr. Navas will be talking about this later. The orthopedic management, critically important, and that's a very rapidly changing area. It's not the same as it was even just a couple years ago, and it's still, I think, going to be changing, and you'll hear from Dr. Ryan Ilgenfritz more about this today. The role of the physical therapist, the occupational therapist, rehabilitation services is critically important as these children make gains in their motor skills. And how do we promote motor function? How do we promote independence as these children grow? We're starting to focus also on other parts of the body besides the nervous system and the muscles that might be affected by this deficiency of the SMN protein. What's the fundamental cause of SMA? So we're looking to see, well, are there risks of low blood sugar in a stress situation? What about the growth of the child? Things of that nature. So we still need to keep a very close eye on the comprehensive management of the child with SMA, both when they're well and have a strategy for the types of therapy and services they need, but also to have a sick plan. What do we do when a child gets sick? And what can we do at home? What can we do if you show up in the emergency room or need to be hospitalized? What about if a child needs an operation? What do we do to make sure that there's proper supportive care? So these guidelines are, I think, very useful because it also empowers the family to be a good advocate for themselves or for their child. Because admittedly, not all specialists and pediatricians, internists, family practice doctors really are not so familiar with SMA. So it becomes almost the job of the child and parent and the adult with SMA to more or less teach your doctor a little bit about what SMA is all about and guide them, hopefully, with the use of these practice guidelines. And to develop a team that works for you. And I think what we've learned is that it's not one size fits all, that we have general ideas of what need to be considered, but it truly does vary from one individual to another. So let me just touch base on a couple things. And as I said, Dr. Navas is going to talk about respiratory support. And here's a little child who is on the vest and the cough assist and the BiPAP and the nebulizer. And the point I'm making here is pulmonary supportive care is changing. It's evolving and it needs to be individualized. So I hope you're able to stay and hear more from Dr. Navas because to me that's a very important topic. Nutrition is obviously huge. because we want to make sure that the child's getting the proper type of calories, that it's distributed properly for the child's growth and also for the nervous system and the muscles to function effectively. And on this very busy slide are just some of the topics that we address in the clinic, and we're fortunate to have an expert dietitian to guide us and help with each family individualize a nutritional plan for that person. As I mentioned, if you get sick, you need to have a sick plan. And we think that's important to discuss when you come in and visit with your doctor. Dr. Ilgenfritz, as I said, is going to talk about the orthopedic management, and that's really two main areas. It's the spine and it's the joint contractures. And how do we deal with those in a child who's being treated for SMA or an adult who is struggling with different issues as well, to make sure that we're dealing with proper comfort and positioning and trying to make sure that we're maximizing function. And this is changing as these children and adults get stronger and respond to these drugs. But we have to remember that in many cases we're dealing with a growing child. So it's not just the SMA itself, but it's SMA within the context of a child that's growing and getting larger and heavier, etc. So important also for your orthopedic doctor is if we are thinking about spine surgery, to remember that if you're getting Spinraza, which as you may know is delivered through repeated spinal taps or lumbar punctures into the lower back area, there needs to be a window to somehow get that procedure done safely and effectively. And this is just a picture of one x-ray where there's a little gap that was left to allow for the administration of the Spinraza. And even for patients that have had spinal fusion, we're learning that we need to be creative with our interventional radiology doctors so that they can try to sneak in from the side to get that needle in so that the drug can be delivered into the spinal fluid. So there's still a lot to learn here. And as I said, it's not a one-size-fits-all. There are general guidelines, both for the care of the patient and for the administration of medications such as Spinraza. And it needs to be individualized to the patient. You're going to hear quite a bit more from Matt about the importance of physical therapy, and Julie with occupational therapy. So I just want to make a point that we do feel that there's an important role for exercise. We don't exactly know how much is safe and what type, but we do know that everyone with SMA is deconditioned, and we need to try to get some cardiovascular fitness as well as just general mobility, and to help with bone health and obviously to promote independence. Let me spend a minute talking about medications. And you might have heard in the news there's quite a flurry of interest about measles epidemics throughout the United States. And there are pockets in the country where children are not being immunized for either religious or personal reasons. And as a physician, we accept that, but I think we also have to understand there's a risk here. And it's something that I'm particularly sensitive to because I've only seen one case of whooping cough in about the last 20 years. And that was in a little baby with SMA, and that baby died of whooping cough. So I'm really sensitive to the fact that we're working so hard, we're struggling to keep these little babies healthy, particularly if they're getting treatments such as Spinraza or some of the new drugs. So in my mind, it is quite important to immunize children, recognizing there may be some small risks, but on the balance, I think it would be a tragedy for a child with SMA to succumb to something that's preventable. That includes yearly flu shots after 6 months of age, the pneumococcal vaccinations, the RSV prophylaxis with the Synagis in the first year or two of life for the type 1 and sometimes type 2 children. And you'll hear a little more about pulmonary management and the use of different nebulizers, bronchodilators, different things to help with secretion management, which again needs to be individualized for each child. Now, there have been a lot of treatments that were tried and unfortunately did not seem to show any benefit in children, even though they did seem to show some response in a test tube. So if you've been in the SMA community a while, you might be familiar with some clinical trials 10 years ago, 15 years ago, with valproic acid and L-carnitine, phenylbutyrate, hydroxyurea, creatine, gabapentin. Unfortunately, none of those showed any benefit, so we really don't recommend those today. Our focus is more on what we would call data-driven treatments where we can actually show both safety and benefit to the child. So those are more of historical support. Of increasing importance is a focus on what we call bone health. So what is bone health? It's trying to make sure the bones are strong enough to support a child who's getting more active and hopefully weight-bearing, crawling, walking, and getting around, and being able to handle the normal spills and falls that all children have without getting a fracture. So bone health really requires monitoring, and that's where we do the DEXA scans, we check the vitamin D levels, what the dietitian is making sure that there's enough calcium in the diet, or that if we need to supplement that. And in some cases, the bones can be quite fragile in SMA, and a child may have a fracture or multiple fractures, in which case we do recommend seeing an endocrinologist, a bone health specialist, to talk about different treatment options. So there are medications such as the bisphosphonates and zoledronic acid, and we're still learning a lot about these. I can't say that you can look this up in a book and say, here's exactly what you should do, but rather we know that we need to address this topic and in certain situations seek out some advice from our endocrine specialists. So I want to switch gears now and talk about some of the approved and emerging treatments for spinal muscular atrophy. And to do so, I want to show on this slide sort of two main categories. So if you think about the treatment for SMA, there are two main strategies. One is to try to target the underlying cause of the disease. So as you know, and I'll show you in a moment, the fundamental problem in SMA is a deficiency of a particular protein called SMN protein. And that deficiency of this protein results because of the genetic change in the SMA gene, the SMN1 gene. So the treatment strategies are to say, how can we get more of this deficient SMN protein, and how can we get it in the target cells that matter most? Those are called the motor neurons, the nerve cells in the spinal cord and the brainstem, that have to send out those long fibers that connect to the muscle and give the signal to the muscle to contract or relax. So it's those motor neurons that we're particularly targeting with these different drugs. And that goes into two categories. There's what's called splicing modification, and we'll get into that in a minute. And that works on the backup SMN2 gene. And there's also gene replacement therapy, where we're saying, okay, if we're missing the SMN1 gene, can we replace that with a normal functioning copy? And with either strategy, the idea is the same. We want to make more of this SMN protein, and we want to make it in those motor neurons so that they can function better, get the signals out to the muscle so that those muscles contract and function. Because without that, those muscles will atrophy. And with atrophy, you lose your muscle bulk and you lose your muscle strength. So that's why it's called spinal muscular atrophy. It's the nerve cells typically in the spinal cord and in the brainstem, and it leads to muscle atrophy. So what we're trying to do here is target the nerve cell and prevent the muscle atrophy. Now there's a second strategy that's listed to the right in purple, and that's called SMN independent. And these drugs don't try to fuss with the SMA genes or try to increase the SMN protein. This is what we call a complementary strategy. What it's trying to do is make either the nerve cell more stable, more resistant to the stress of having SMA, or to function on the muscle itself. And so we'll talk a little bit more about this. So this is not trying to fix the underlying problem, but rather it's trying to say, okay, maybe we can make the muscle function a little bit better so that the nerve and muscle as a unit provide better strength and endurance for the child. So let me spend a moment just talking about drug development. Because I think for those of us who deal with children with and adults with SMA, we look at these clinical trials as a treatment opportunity, and they are, but I think we need to keep in mind that they're investigational studies. They're experiments. And we're trying to identify in a small number of patients how safe is the drug and how well does it work. And this drug development happens in different phases. And there's the phase 1, which is typically looking at the safety of the drug, how well is it tolerated, how well do the procedures go, such as doing the lumbar punctures in little babies, as well as what's the safety of the drug itself. Are there side effects with the kidney or the liver or the blood count, things like that. And it's also focusing on trying to find what's the optimal dose. So that's phase 1. And then once you've gotten through that and you say, okay, we think we know what the optimal dose is, and we've been able to identify that we think it's safe, then you go to phase 2, which is where you're trying to determine, well, does the drug work? At least can we first get what's called proof of concept to show in a small number of patients, does the drug seem to show any benefit? And it's based on that phase 2 data or information that then typically there's a big phase 3 study. And that's where there's a lot of patients, and traditionally there are two groups. There's a group that gets the drug, and there's a group that does not get the drug. That's the placebo group, or what we call a control or comparison group. And in most drug development programs, you need to have what's called an internal control group. So there's, let's say, half or 2/3 get the drug, and a half or 1/3 do not get the drug, and everybody's blinded, so we don't know who gets the drug and who doesn't. And that's the way that traditional drug development has occurred. And that was, in fact, the way that the program got started for nusinersen when it was in clinical trials. That drug is now Spinraza. But there's some challenges with that. And the FDA and the European counterpart, called the EMA, listened to the doctors and the drug companies and saying, you know, this is a really hard thing to do for SMA, to have what's called a randomized controlled study, which is this gold standard. So some of the drugs that are in development do not have an internal control. And that poses a particular challenge, because the drug company has to say, well, if we don't have something to compare it with, we have to compare it with what we call the natural history, or what do we know about SMA in general. So, yeah, and the FDA sets the bar much higher to be able to get a drug approved if you do not have what's called this internal control group. This was a challenge for the drug development for Spinraza. Unfortunately, they met that standard and showed that the drug was safe and showed good benefit, and it got approved. And you'll hear in a minute, I'm going to talk to you about some other drugs in development and how that's progressing. But SMA is kind of a particular case, and it's changing. So it's a very interesting and challenging time. So let's go into some of the specifics now. So over here is nusinersen, and it's completed all the clinical testing that was needed to get approval by the FDA and the EMA in Europe. So it's now Spinraza, but there still are clinical trials in progress. So the company Biogen that's developing the drug is still looking at this in the context of new babies who have been identified shortly after birth, and they're pre-symptomatic, and they're being treated before even any symptoms of the SMA evolve. And they're also, to their credit, doing a 5-year extension phase of the children who are in the clinical trials so that we can still learn from them going forward. The AveXis 101 is the gene therapy, and you can see it's right at the tip of the phase 3, and it's under review by the FDA, and we could hear it today, but it's supposed to be within the next few weeks. So we may have a second treatment for SMA available by prescription in the near future. And then just a bit behind that in the timeline is a drug being developed by Hoffmann-La Roche, and that's a Swiss pharmaceutical company. And they have a drug that is in advanced phase 3, and the word is that they're likely to prepare an application to submit for regulatory review and hopefully drug approval somewhere in the next several months or a year or so. And I'll just briefly touch on these other two categories in a moment. So let's move forward. I'm going to give you a little refresher on genetics because this is important to understanding how these different drugs work. So in a typically developing child or adult, there's 2 copies of a piece of DNA, what we call a gene. There's the SMN1 gene to the right, and this SMN2 gene to the left. And they're almost identical, but not quite. And they differ by just one letter. One DNA letter is really the most important thing. There are a few other letters that differ, but there's one right here. And think of the gene as a book that has different chapters. And this one letter is very important because in the majority of cases, that book is printed without chapter 7. So you have chapters 1, 2, 3, 4, 5, 6, and then you have 8, but you're missing 7. And it turns out 7 is very important. So that's the fundamental difference between the SMN1 gene that includes all 8 chapters and SMN2. That in most cases is missing that chapter 7, or what we call exon 7. Okay, and those 2 genes lie almost next to each other on chromosome 5. Okay, there are other forms of SMA, but what we're talking about today is classic SMA that's linked to this chromosome 5. We're not talking about some of the other rare forms, because the treatments that are being identified really only work for this particular form of SMA. Okay, now you have these 2 genes, SMN1, SMN2. They make exactly the same protein. And that's some of the beauty of these different treatments, is that you can focus on either the SMN1 gene or the SMN2 gene, because either way, it's going to try to boost up and make more of this deficient protein, which is what's so necessary in the nerve cells. So that's shown here. Okay, so to the right, you can see here's the SMN1 gene with all 8 chapters, and here's the SMN2 gene, and in about 90% of cases, you can see it's missing that chapter 7, and it's only about 10% that actually includes it over here, okay? And it's that little bit, that 10% that includes it, that does make a little bit of protein, not a normal amount, as you'd see represented here from the SMN1 gene, but just a little bit, and that's enough to keep those nerve cells barely functioning, and unfortunately not for very long. And 90% that are missing that chapter 7 do not make a functional protein. So how is this important? Well, here's a child or adult with SMA. They are lacking a functional copy of the SMN1 gene. They're not able to make any of the protein from that SMN1 gene because they don't, either it's missing or it's not functioning. So they're totally dependent on this backup SMN2 gene represented here. Okay, so one treatment strategy is, well, let's replace the SMN1 gene, and that's what the gene therapy is all about. The AveXis drug, Zolgensma. Okay, so it's trying, and I'll show you a little more about that in a moment. So that's treatment strategy number 1. We're going to replace the missing or non-functional SMN1 gene. The other treatment strategy is on the left, and it's to say, well, can we find a drug that shifts that balance from 90% not having chapter 7 more to like 50-50, where maybe half of the, what's called the RNA, now includes chapter 7 and makes more of that protein. So remember that the protein that's made from SMN1 and SMN2 is exactly the same. So the nerve cell doesn't care where it comes from. Okay. But it's a matter of when to deliver it, how well does the drug get into the nerve cell, how quickly does it work, how much of this SMN protein is actually made, and how sustained is that response? In other words, how often do you need to dose the drug to maintain that production of the SMN protein? So let's talk about nusinersen, now Spinraza. So this is a little picture of that chapter 7 over here on the left, if you can see my pointer there. And this is what we're trying to do, is include this chapter 7. And there have been a variety of different treatment strategies. So the way nusinersen works is, this is what nusinersen is in the red. It's these 18 little letters of DNA-like material, and it's designed to attach to one specific area in the whole body's DNA. So our body has 3 million letters of DNA, and this is designed to attach to one unique area that has 18 letters, and it's called complementary to this area. And what it does is, by blocking there, it pushed away those inhibitory factors. So these guys here, we want to get rid of. We want to push them away and allow this thing up here, called a UNSNRMP, we want to get that to bind down here. And if we can get that to bind, it's going to include that chapter 7. So we're going to bring in our Spinraza. It's going to push away those blocking factors. It's going to let this U1-SNRMP bind. And by doing that, it allows chapter 7 to now be included. So you could call this a workaround strategy. It's not fixing that one letter that I showed you that was causing the problem to begin with. What it's doing is it's coming through the back door and saying, okay, we found another way to try to get chapter 7 included here. Now, this is the way nusinersen works, and there are other drugs that are also called splicing modifiers. That's what this is. It's affecting the splicing. It's trying to promote inclusion of that chapter 7. So the risdiplam, which is the drug being developed by Hoffmann-La Roche, is an oral drug. It's designed to work in a similar way. Not exactly the same as nusinersen, but again, to modulate the splicing, change it in a favorable way such that chapter 7 is included. And there's a third drug that has been under some limited development by Novartis called branaplam, which also works in a similar way. So there are 3 drugs that have been in clinical development, all looking at what's called splicing modification, and this is looking at the backup SMN2 gene, again, as compared to the gene therapy or gene transfer, which is focusing on the SMN1. Okay, so 2 different strategies. Okay, so here we go, and we make more protein, and we're good. So just to remind you that SMA, if you're treated with nusinersen or Spinraza, it's repeated lumbar punctures. And it's gone remarkably well, even with little fragile babies and even newborns. It's gone very well, but it does require quite a team. Fortunately, this drug has a long duration of action. So once the drug is loaded up in the system through what we call the loading doses, then you only have to give it every 4 months. And that's a good idea, that you don't have to do it weekly or monthly, but every 4 months seems to work very well for most patients. But actually delivering the drug effectively, it takes a village. And at our hospital, we're fortunate to have Kelly, who's going to talk to you a little bit later about really how do you organize all this? Because I think a lot of doctors, a lot of clinics, hospitals struggle with administering the Spinraza. And Biogen provides some support to try to teach you how to do it. I think we're going to face some similar issues with the other drug treatment options as they become available. And they're each going to have their own specific challenges. But so we have a checklist, and you're going to hear more about some of the specifics here. But I think in general, I've been hearing that doctors who try to do this in, let's say, a private doctor's office really can struggle doing this, and I think we've been a little more effective having a team approach, and we have dedicated people who work to get the insurance authorization, to schedule it with the interventional radiology doctor if that's the way we're going to do it, things of that nature. So I just want to point out that that's, I think, quite important. So how did this drug, nusinersen, ever get approved? How did we show that it worked? Well, through the phase 2 study, remember that's the middle one, and that was the proof of concept. Well, it showed that in the red here that the babies that were treated did better than the group in blue who were untreated in a different just historical study. So it seemed like it improved survival, but to at least my surprise, not only were they living longer, but we were seeing an increase in their muscle function, and that's represented by these red arrows going up. I think going into this, I didn't really expect that this drug would do more than stabilize and prevent further decline. And in these very fragile, very weak babies, in fact, we were seeing improvement. And that was really a game changer. And it was based on that then the phase 3 study and the whole idea of, gee, we can look at SMA as a treatable disease now, not just a drug that stabilizes, but we're actually seeing improvement in motor function. So when we saw that, that really changed everything. And I think it changed the whole field and the whole thinking about SMA, not just for nusinersen. So let me just show you some videos of one child and my thinking as this progressed. So here's a little guy. So this is a video, and you can see our little guy here is not moving very much because he's a typical type 1 SMA, little baby. And this is right as he was first being treated, just before. So here he is a year later, because he was treated at 2 months of age. Here he is a year later at 14 months, and he rolled over. And that, to me, was striking because babies with type 1 SMA never roll over. So when we saw that, that said, gee, this is a transformative drug. And then here we are about a year after that. He's now about 2 years old, and he's sitting up. So again, not only is he sitting, but he's learning very important social skills, as you can see here. Okay. So sitting is a type 2 skill. Well, I'll leave the audio on. So here we are at 3 years of age, and the parents have graciously allowed me to show these. These are all available on YouTube. So here he is, almost 4. Now he's still very weak. He's needing to wear some body support and some support on his ankles, but you can see he's weight-bearing. He's very eager to walk and work out in the gym on the parallel bars there. So what's the point here? The point is we don't know where this is going to stop. This little boy continues to make steady progress, and I think that's been true of virtually all the patients that I've seen treated, but they progress in different ways and in different rates, and it's been very, very difficult, even if you just look at the Spinraza-treated patients, to be able to predict how one child's going to do. I think we've been very pleased to see that they also improve in their pulmonary support, that over time they seem to be able to handle colds better at home, and they're not coming into the hospital every time they get an infection, that they're starting to eat by mouth and not needing the G-tube for feedings. They're starting to talk, and boy, can these kids talk. So it's really quite gratifying to see these little babies actually grow up into functioning children and to continue to improve in their motor function, in their feeding, their speech, their breathing. And now we're really struggling with new problems. What do we do about school? Gee, we never really thought about school before for these babies. Well, what about the infection risk? Oof, we don't want our little babies getting infected, but we do want them socialized, we do want them educated. That's a problem that we're now struggling with, and we don't have that answer yet. So that's just one example. Let me just show you a few more examples to give you sort of a broader overview. So here's our little guy. So where are you, Asher? So this is a little fellow, and here's a video from not long ago. Okay, and these are literally his sort of first steps, and this is just a few months ago. So it sort of takes your breath away, or at least mine. And I think what I'm learning is that we shouldn't set any limits for these children. At least not in my mind. My objective is to see every child maximize their motor function and become independent functioning young adults. And I think, as exemplified by just the two examples I showed here, I think that's possible, and we're seeing this with the other drugs as well. Let's talk about this little guy. Now, what's different about this little boy, Chance? Because he had, unfortunately, a little sister who died at 7 months of age before there were any drug treatment options. And she was a typical type 1. And you can see he's a sort of robust little boy. Here he is at a year of age doing what 1-year-old boys do. Okay. But he's sitting, okay. And just for the sake of time, I'm going to move forward quickly. And here he is walking, and he's walking, not only is he walking, compared to his sister who unfortunately didn't make it past 7 months, who never rolled over, never sat, but here he is walking at a normal age, and he's continuing to make good progress. Now the little girl on the right, Kenna, again with permission of the parents, I'm including these, she's just too cute not to include. And she's ready to go to school, it looks like, or, I don't know, to work. So now what's the difference between Chance and Kenna? Well, there is some difference that we're starting to appreciate, because Chance has 2 copies of the backup gene, of the SMN2 gene, and Kenna has 3 copies. And Kenna has a brother with type 2. So she would have been predicted to be a type 2, but she was also treated in the first few weeks of life. So what we're seeing is, if you compare things, and on this kind of busy graph, you can see that down here in the black and red lines, it's a slow, steady improvement we're seeing in children with type 1 SMA who were symptomatic, meaning they were weak, when they started treatment. And they just keep moving along, and this is now out at over 4 years that we're following these children. But look up here at these 2 upper lines. These are the babies treated before symptoms were apparent, what we call pre-symptomatic. These were all treated within the first month of life. And you can see they're doing spectacularly well. In fact, better in comparison to the symptomatic. And you can see that the babies who have 3 copies, such as Kenna, seem to do a little bit better even than the babies like Chance with 2 copies. So what have we learned from this? Well, we learned that SMA is treatable, and in the symptomatic patient we see slow, steady progress when treated with Spinraza, and we've learned that if we can treat them even earlier, before symptoms have started, that we see even a more robust response, and that we're seeing in the majority of cases that these babies are developing normally, and they're not needing to get feeding tubes, they're not needing breathing support in most cases, and they're developing normal, what we call milestones at the normal age. So that has led to an initiative to do newborn screening, to say, well, why don't we try to identify all these babies with SMA before birth? So I know that doesn't help you if you have SMA or you have a child with SMA and you're living with it now, but if we look over the horizon, I anticipate that the majority of children with SMA are going to be picked up through newborn screening, and here in Florida that was recently approved by the State Department of Health, and over the next year I expect that will roll out. So in the near future, there's going to be really two groups of patients with SMA. We're going to have everyone here in this room who's living with SMA, and there's going to be this new group coming forward that was identified pre-symptomatically, treated before any symptoms were apparent. So we're going to need to struggle with that because we don't really know what to expect, how that group's going to do over time either. So what about the real-world experience? Because after Spinraza was approved in December of 2016, which is a little more than 2 years ago, the drug's been available in several countries, and several thousand children and adults have been treated. So what we're learning at our medical conferences, and these are reports from Germany and Italy and France, and they're starting to pour in, is that older patients with type 1, a 3-year-old, a 5-year-old, a 10-year-old can still respond to Spinraza. But the expectation should be different. It's not the same as treating somebody who's been recently diagnosed who's 3 or 4 months of age. And it's certainly different from the pre-symptomatic treated patient. So we still have a lot to learn in what we'll call the real world as a variety of patients are being treated. But I think the current, here we are. Okay. Here's our video. So this is the little girl with the backpack. Okay, escaping. So what I think we're all learning as doctors treating patients with SMA is that virtually every patient should be looked at as capable of responding to these treatments, at least for nusinersen, where we're having this experience, but that the expectation should be different. And it might be more of a stabilizing drug with somebody with more advanced disease. We may not see the improvement that we see in the young babies. Okay? The other thing that we're focusing on are teenagers and adults who have type 3 and type 4, because they really weren't studied in the clinical trials. And the drug was fortunately approved for a broad range of patients. And we're just starting to get some reports from different groups in the US, particularly from Stanford University in California. And they're following about 30 adults. And as you can see here, from ages 18 to 65 who've been treated. I think there are some particular challenges in treating adults, but they've been able to work through that, and they've been able to show that those adults are showing some modest benefit. It's slow, but at the minimum it seems to be stabilizing, but we're getting some early clues that we're seeing even some early improvement in things like the breathing function, pulmonary function. So there's a lot more to learn over these next few years. So let me move forward and just spend a few minutes on the other drugs that are still in clinical development. I had mentioned before the other splicing modifier under development by Hoffmann-La Roche, and that's called risdiplam. And how is that different from Spinraza? Well, it's oral, so that's nice. You don't have to have the spinal taps. It's something you would take daily by mouth instead of every 4 months by spinal tap. It may have an advantage in some ways because the drug goes from your stomach into the bloodstream to all the tissues of the body, not just the nerve cells in the spinal cord and brain. And that may have some potential advantage over Spinraza, but we don't really know that. But at least the results so far are very favorable, and we're seeing improvement in the babies with the type 1 and the children with type 2. And they're also starting a pre-symptomatic study. We are concerned about some potential toxicity, as we are with all drugs, so we're watching carefully for any side effects from this drug and all the others. But so far, it seems to be remarkably safe, and the babies are tolerating it very well. So that program is marching along very favorably, and we should be, I would expect that we'll hear some more about this over the coming months and year. And this cartoon just basically shows that the drug works similar to the nusinersen. It works on that backup SMN2 gene. Okay. There's different studies that are ongoing, and they all have a fish name. So there's a firefish, sunfish, jewelfish, rainbowfish, this, that. The company's been very good at trying to demonstrate how the drug responds. They've been able to show that they can measure, actually in blood, that the SMN protein level goes up. So that's really a very important finding, that you can monitor something in blood to show that the drug works. And the other splicing modifier that I mentioned by Novartis is called branaplam, and that's still in a more early phase of development, and we may hear more about this at the coming meetings, but there hasn't been anything recent about this. But it works similar to the risdiplam. It's an oral drug that is designed to increase the amount of the SMN protein. So let's go to the gene therapy now. Okay, so this is being developed by a company called AveXis, and it's a gene therapy development company. And this particular drug is called AveXis 101, and it's now recently been given the name Zolgensma. And it's called a gene transfer therapy. And what do we mean by that? Well, it's trying to transfer into a child or adult with SMA a functioning copy of the SMN1 gene. Okay, so, and how does it do that? Well, it has to package the gene, and that's shown here in the blue. So it takes the human SMN1 gene, and it packages it inside a virus. It's a little bit like packaging something in a rocket that you're trying to send up to the space shuttle. Okay, so you can't just inject the gene itself. That doesn't seem to know where to go. So you need to target the gene to get to the nerve cells in the spinal cord and the brain. And so it does that by packaging the gene inside a virus. That's called an AAV, or adeno-associated virus. And there's one particular type that's used here. That virus doesn't actually cause a disease. So that's great. And it's a common virus. Everybody can get exposed to it. It doesn't cause disease. But you can utilize it as your rocket ship, because it knows it has an affinity and it targets the nerve cells. And the beauty of it is that you can inject it intravenously in the little babies, and it can cross over and get into the spinal fluid, the brain system, which is something that most drugs cannot do. But this virus is sneaky. It can go from the blood, it can get into the brain, it can deliver the package, which is the gene, the SMN1 gene. It can deliver it to the motor neurons, which is the target, and it can set up shop. And once it's in the motor neuron, and that's shown here, and there's a way that this virus on the top gets into the nerve cell in how it sets up shop here, and then it just starts cranking out this SMN protein. And part of the beauty of this is it should be a one-time treatment. So you treat it once, it delivers the DNA, the gene, to the motor neuron, and as long as that motor neuron is functioning and that gene should continue to function, it should, for the life of that nerve cell, continue to make SMN protein. You don't need to retreat. So with that in mind, AveXis did undertake a gene therapy study in 15 babies, and There were 3 at a lower dose, because this is, remember, the phase 1 is a dosing study, and 12 at a higher dose. And what they showed is that all 15 babies lived much longer than were expected. And in addition, if you look at a motor scale, the low-dose babies sort of stabilized or came up a little bit, but there was a remarkable increase in the babies treated with the higher dose. Okay, shown here, where they went up on this, up as improvement using a motor scale. And they did so well that they sort of hit the limit, what we call the ceiling. It wasn't that they actually stopped getting better, it's just they were doing so well, this scale couldn't capture any further improvement because it wasn't designed to go beyond that level of motor function. So with that, the company AveXis has progressed with some other studies, and there's a phase 3 study called STRIVE, and then there's one for type 2 children called STRONG, and they're doing also a pre-symptomatic study, which is called SPRINT. Now, AveXis has submitted their package to the FDA last fall, and it's under a 6-month review, and as I mentioned earlier, it's expected that we will hear from the FDA, hopefully favorably, that this drug will be approved within the next few weeks. So then we have a problem, and it's a good problem. We have a problem where we'll have more than one drug to choose from, and we know a lot about the Spinraza because it's been available now for a couple years, and we have a lot of real-world experience, and now we have this new exciting gene therapy that's coming online, and we're going to have to figure out, well, which is the right treatment for a particular patient, and will the insurers allow the doctor to make the choice, because these will be expensive drugs. So there's a lot that we still have to learn, and we're kind of anticipating the arrival of the Zolgensma shortly, but we're also anticipating there'll be a little chaos initially till we get it all sorted out. Okay, so now I want to finish up in the last couple minutes with what are called the muscle modifiers. So there's a company called Cytokinetics, and they've developed this drug, I can't even pronounce it, reldensemtiv, and it's also been called the CK2127107. Drugs often have those funny numbers. And this was designed to make your muscle contract stronger. It didn't fix the SMA, it didn't try to increase the SMN protein, it just said, okay, if you're improving how the nerve works, what can we do at the muscle end? Because the nerve and muscle work together as a unit. So how can we get the muscle to work better? So the strategy here was, let's see if we can develop a drug that takes the muscle and gets it to function stronger. And I'm sure that athletes would love to get a hand on this because it probably would be considered a muscle doping drug. It's certainly going to be illegal in that setting. But here, it was actually in a clinical trial, and the preliminary results that have been shared so far seem to show that it had a modest benefit. And there was maybe some slight improvement in endurance, actually not strength, but endurance, which is a different story. How long can you sustain a task, such as walking at a certain pace, versus how does it make you stronger when you try to lift up more weight, for example. So it seemed to actually improve endurance, which is very important because fatigue is a major factor in SMA. And it also, there was a hint that it might be improving pulmonary function. So we're waiting to hear more from the company as to their path forward and see where that's going. So the day may come where we're looking at combination treatment, a drug that focuses on increasing the SMN protein, and that would be either the Spinraza or the Zolgensma or the Risdiplam that we talked about, combined with another drug that focuses on the muscle functioning better. Okay, so that's where we're thinking over the horizon, where things are going to end up someday. There's one more drug that I just want to, mention. There's a drug called alesoxime, which was in clinical development. There were clinical trials. It started with a company called Trophos, and then Roche took it over. And it's a mitochondrial stabilizer. It's designed to stabilize these nerve cells, the motor neurons, that are working so hard. It's trying to say, hey, calm down. We're going to stabilize you so they don't get overly stressed out. It's like trying to not run your car engine too fast. And that drug did seem to show some benefit, but the company Roche elected to shelve it for the moment, in part because it wasn't clear there was a market for this. And there's certain realities, of course, that drug companies have to take, because these drug development costs are enormous. So they have to be able to get some return on it. And now that we have drugs focusing on the fundamental cause of SMA, that increase the SMN protein, it does sort of call into question, well, what's the marketability of a drug that sort of is a stabilizer? And I'm hoping it might come back because it actually seemed very safe and it did seem to provide some benefit. So it may be something that, again, would be used as a combination therapy. The final one is Scholar Rock. And now this is, you're not going to be able to read about this yet because it's not on clinicaltrials.gov, but it's coming soon. And this works on something called myostatin. And it's kind of a clever idea, and it's been used in muscular dystrophy for several years. Unfortunately, it hasn't really shown benefit in muscular dystrophy, but I think this company takes a new strategy. Your body has certain factors circulating around that promote muscle growth, and there are other factors that sort of put the brake on it, because you don't want your muscles to overgrow. It should be a balance. So one of the chemicals that puts the brake on it is called myostatin. And the idea here in this strategy is maybe we could release the brake a little bit, release that inhibition, allow the muscle to regrow a little more so there's more muscle target for the nerve cells to work on. So remember, it's called spinal muscular atrophy. So if we can work on the atrophy part, if we can build up the muscle, then maybe the nerve and muscle as a unit will function better. So this company has developed what's called an anti-myostatin drug. So think of it as trying to inhibit an inhibitor, or taking your foot off the brake and letting the gas do a little, get a little more acceleration, so to speak. And this is a drug that will be given repeatedly intravenously. There is a phase 1 study that's in progress. There's a phase 2 study that's in the planning stage, which should start in the United States shortly, meaning in the next month or so. And it's going to be for type 2 and type 3 patients, from what I understand. But there is no information really publicly out there yet, but you'll want to keep that in mind. So with that, I'd like to wrap up. And I hope I've been able to emphasize that SMA is a treatable disease, that nusinersen is now a treatment standard, that gene therapy will hopefully be a second treatment option soon, that there are other drugs in the pipeline. And I hope I've convinced you through some of the videos and the demonstration up front here that SMA is a different disease. It's not the historical. We have to get away from that. We have to be more forward-thinking. And there are going to be new challenges, not just for the neurologists, but for the pulmonologists, the orthopedic specialists, the physical and occupational therapists. We're all learning every day new things. And I think importantly that we've learned that earlier treatment makes a difference. So when given the option, we really want to get treatment started early, after diagnosis, or even before any symptoms, pre-symptomatically with the newborn screening. And so what does this cartoon mean? Well, this is an important medical journal, and it's designed to show what I'm thinking about old SMA and new SMA, meaning things are changing. So with that, I just want to thank you for your attention and highlight a few of the many, many people I've had the wonderful opportunity to work with, both in my clinic at Nemours and nationally, internationally, and with a lot of support from the pharmaceutical companies and the FDA and others. It's been a wonderful journey, and it's just beginning. Thank you very much. So, Blake, do we have time for a couple questions, or how do you want to do it? All right.
If you have a question, please raise your hand and I'll bring the mic over.
So who's this little girl? While we're waiting for the first question. She's a little girl with type 3 SMA, and she's allowed me to use her picture as a daily reminder, as my screensaver. And so she has lost walking, and she's now under treatment, and we're trying to regain that. Okay, so first question.
It may be a little too soon to know this, but I thought I'd just ask anyway. Are there any indicators yet that whether Spinraza or AveXis is more effective in a certain age group? Like, for example, my son's 5, as you know, so just wondering if
right. So, a very important question. So, how do we compare the relative response benefit from the different drugs? And there are efforts to try to do this, and AveXis presented a report at one of our meetings last fall trying to compare AveXis with Spinraza. And it was a first look, and I think there's a lot of challenges in trying to do that effectively, because it is difficult to match the groups, because the children in the AveXis study weren't quite matched the same as those in the what's called the ENDEAR study. Similar in many ways, but different in some important ways. But if taken at face value, it looked like the babies with type 1 SMA who were treated with the high dose of the gene therapy, those 12, so it's limited to 12 babies, actually showed an earlier response. And it took a little while relative to the response we saw with nusinersen or Spinraza, and that the motor response seemed to be a little steeper, a little more rapid. I think we're waiting to see if that's replicated in the bigger phase 3 study, but certainly the drug works, and it works well. There's no question there. Being able to do an effective comparison with that, or even with the risdiplam, which is the third drug that we're struggling to better appreciate, I think is still going to take a little bit of time. But so ask me that question in another year. Maybe another question or two?
While I see lots of studies for individuals, case studies supporting the use of the drugs for SMA type 1 and 2, can we hope to see more studies supporting the use of the drug for type 3 patients?
One more time. I had a little ambient noise, we'll call it.
Well, we see lots of studies supporting the use of the drugs with type 1 and type 2.
Sorry, one more time.
Well, we see lots of support for the drugs in cases with individuals with type 1 and type 2 SMA. Can we hope for more studies supporting the use of these drugs with SMA type 3?
Okay. So the question is, what about type 3? Do we need more studies, or if the drug's approved, can we learn about how it works in what we'll call the real-world setting? I mean, there's two ways to sort of learn things. So I think the drug companies are trying to balance the idea that if the drug works, we want to get it approved as quickly as possible and make it available to as many patients living with SMA as quickly as possible. So the challenge is, as you point out in your question, well, if we don't have clinical trials in type 3 in ambulant patients, how do we know how to make a decision whether or not we want to be treated with that drug? So the drug company has to say, well, is it important to do a study in type 3? Or is it, maybe if once we get the drug approved, then we can look at that population in a different way. So in the case of nusinersen, we didn't have really any data to support the use of Spinraza for type 3 or adults with type 4. They just weren't studied in the clinical trials, as you've mentioned in your question. But what Biogen has done is to support a registry, actually several registries, to try to capture how patients, type 1, type 2, type 3, type 4, how those patients are doing in the real world when they're being treated with Spinraza. And so we're trying to capture what's called real-world data, and these are patients being treated at medical centers by doctors around the world, and trying to answer your question. I think there is a challenge sometimes getting insurance companies to pay for the drug when you don't yet have any data from a clinical trial that supports its benefit. So on one hand, the FDA gave a very broad approval, what's called the label, for virtually anyone with SMA, type 1, 2, 3, type 4, of any age, from little babies straight through adulthood. The problem is the insurers sometimes look at it differently. So we do need the data to be able to support that, and that's why some of the studies, like what I mentioned at Stanford, where they have 30 patients, and they're following them and trying to identify the response, those are so important, and there's other studies being done in other countries looking at adults as well. So as far as other drugs like the gene therapy, well, they're taking more of a laddered approach, saying, well, we know the most about the babies with type 1. Let's try to get approval for type 1, and then we'll see about type 2, type 3, over time. So they are thinking about doing other studies in other populations, and I think you'll be able to hear more about that and address that to representatives from AveXis at the roundtable this afternoon. But good question. Thank you.
For Dr. Finkel?
Is there any new information about lack of systemic SMN protein as opposed to just motor neurons?
So that question gets to a broader issue of, okay, if we're targeting our drug to motor neurons, such as with Spinraza, what about the deficiency of SMN protein in other tissues in the body? Is that going to be important? Are we going to start to see problems arise down the road if we're not actually boosting up the SMN protein level in the kidney or the liver or the pancreas? And the answer is we're concerned about that, but we're actually not seeing much yet, at least not in the nusinersen patients. It's actually, because we're now following these children 5, 6 years, at least that's what I've been doing, and I'm still very much focused on that and trying to watch for any concerns when we do the blood work or check the urine and all that, and make sure that we don't get into problems with low blood sugar or all that sort of stuff. But so far, that hasn't actually been the case, but it's a really important question, and at least theoretically, the gene therapy and the risdiplam, the oral ones that go to all the tissues, that may be an important advantage, but at the moment, I don't think we can say that. Very good, I wore you out, so thank you for your attention. Okay, and we'll let Blake move on with the program, and I'll look forward to seeing you later this afternoon. Okay, again, thanks.